Hi, welcome to another episode of Talking with Docs. I am Dr. Paul Zalzal.
And I'm Dr. Brad Weening.
So today we have a touchy-feely type topic. It is communication. We're going to talk about communication.
Critical to the consultation as well as setting realistic goals for the team.
Right. And if there's any sort of patient dissatisfaction, most of the time it is because of poor communication. So we want to talk about sort of both sides of it. First part, we're going to discuss a little bit of advice for young physicians or medical students or residents or
old physicians.
Or old physicians, just not middle-aged physicians.
That's right.
Things that that can run into some pitfalls with communication with patients. And on the other side, we're going to talk about
patience. So what can you do to be a better communicator and convey not only your concerns, but also let your doctor know kind of what you're thinking about?
Communication.
Okay, so where do we start?
Let's start with the docs, okay?
Okay.
I mean, I see second opinions every now and again for someone who's got like a painful knee, they had a knee replacement that still hurts, that kind of thing. And often the patient will come in and they'll be very upset with their previous physician or previous surgeon.
Yes, usually the way I tease that, I was like, oh, you had your knee replaced a couple years ago by Dr. So-and-so. I said, is there any reason that you didn't go back to them? And they go, no, not really. And then sometimes I will ask, I say, sometimes people just have personality conflicts or they don't get along, and they're like, yeah, we didn't get along. And that happens to all of us.
Yeah, boy, by no means am I saying I don't have patients that are not happy with me.
Absolutely.
If you're out there in Washington, you're my patient, I'm sorry. But I know I have patients who aren't happy with the way I communicated, and it's the kind of thing that we get better and better at as we go on. I'm always trying to improve myself in this regard. So, yeah, if to the young doctors, new doctors, you got to listen to your patients, and if you can't find out what's wrong with them, or you can't come up with a diagnosis, I think it's a bad way to communicate, say there's nothing wrong with your knee, or there's nothing wrong with your hip.
Totally agree.
It's more like, well, I can't find out what's wrong with it because it's outside of my area of specialty. For example, in the knee, it looks like it's not coming from the meniscus, the cartilage, the ligaments, the tendons. It's not coming from that stuff. Maybe it's coming from the nerves or the blood vessels, or something that's outside of my area of specialty. So what I often say is, look, I can tell you're in pain. I can't figure out why. I'm going to try and get you to a specialist or a doctor, or maybe it's your family doctor or someone who might be able to help you. I just can't with my tools that I have.
Totally agree. So validate the patient's pain, acknowledge the fact that you believe that it is real and that it's a problem, and that you're going to do what you can to try to help them. And that potentially could be sending them back to their family doctor or to a different specialist.
Yeah, is that fair?
Yeah, absolutely.
It doesn't help anyone if you're a young physician or a trainee and you're going to be out in practice. It doesn't help anyone if you say, I think it's in your head.
No, I think you should never say that. Even if you think that, you should never say that.
Well, everything's in your head because that's where your brain is.
Sure.
So it's just a matter of how's that signal getting to your head.
Yes.
All right. Is that signal getting to your head part of my area of specialty? Yes or no? No, I can't help you if it's not.
Yes.
But it's still, you might be feeling the pain in your knee, but it's coming from somewhere else or for some other reason. Of course, you feel it in your head.
Yeah.
So medical students, residents, don't ever tell a patient that you think it's in their head.
I think the other thing too, when you get on that path with somebody thinking, oh, I can't help this person, people potentially can become dismissive and don't want to hear the rest of the story or maybe cut their exam short or whatever. But I think you just do exactly the same examination every time, give them your full attention, and then at the end say, listen, I hear you, I recognize you have a problem, here's what I think I can do, and that might be nothing, and if not, we're going to send you on somewhere else.
Fair enough.
Okay, what about patients? Where does the responsibility for good communication fall with the patient? Are all your patients good communicators?
Well, you know what, I'm lucky. Most of my patients are good communicators, but there are a few key things. One is when the doc's going to ask you questions, and they're going to start with open-ended questions, like how are you doing, what's wrong, what's bothering you, and then the doc's going to, it's like an inverted pyramid, going to focus down to some specific questions.
Yes.
When you get down to those specific questions, your doc is trying to get a picture, and he's got something in his mind, an algorithm, so you got to answer them specifically.
Yes.
So I'll give you an example.
Okay.
Ask me, what's wrong?
Paul, what's wrong with your knee?
Well, my knee's been bothering me now, and it's been getting worse. That kind of thing. Open-ended question, open-ended answer. Ask me a specific question like how long can I walk, or how far can I walk?
How far can you walk?
Well, it's funny because when I was 16, I fell out of a tree.
Okay, so how far can you walk?
Well, that's the thing. My dad had his knee replaced right around the same age as me, so yeah.
So how far can you walk?
Pardon?
Yeah, it happens.
So you want, when someone asks you a specific question, just try and give the specific answer.
And I think actually back to the doctor side too, maybe sometimes if you're looking for a specific answer, don't ask an open-ended question. Ask yes, no questions, or 1 to 10 questions, or something that people have to commit to an answer to.
By the end, my questions are multiple choice. A, 1 hour. B, 2 blocks. C, to my car. That's it.
Absolutely. Makes sense. So another piece of advice for patients is give some thought to the potential questions that you may be asked, or try to, before you get to your consultation, identify things like chronicity. When did it start? How long does it last? What makes it worse? What makes it go better? What makes it go away? Things like that.
Watch our videos.
Watch our videos, and that's why that's one of the reasons we did it, so people are armed with more information before they get there.
Okay, and the other tip to the patients is don't wear your sunglasses indoors.
What about transitions?
Transitions are fine because they'll eventually. But that's sort of one of the red flags when we're talking to each other. Say, oh yeah, well I don't know. She wore her sunglasses inside through the whole thing. It's hard to communicate with someone. Nobody's future is so bright that they got to wear the sunglasses inside.
I think Tin Buck 3 addressed that.
So yeah, you know what? We want to be able to communicate with you. Take off those shades once you're inside.
Yes, I would agree, unless you're light sensitive. Yeah.
If you've had like cataract surgery recently, you have some. In the absence of ocular pathology,
okay, fair enough.
Don't wear the shades.
Yeah. No, and I think the other thing is try to come with one specific problem that you want addressed, because that's hard when it's like, oh, my shoulder, my back, my knee, my hip, and then we just try to narrow it down and say, listen, let's try to address one of them, and then we're happy to move on after, but let's just do one at a time.
Good point. Allergies.
Yes. The bane.
The reason that your doctor is asking you about allergies is because he doesn't want to prescribe something at some point in your encounter or treatment that you're allergic to, in the sense that you have a rash or an allergic reaction that will close your throat and be potentially fatal.
And usually this doesn't mean like dust or wool.
We don't prescribe a lot of dust and wool.
So in orthopedics, I would say it's medications, it's latex, and potentially metal allergy, which again is very, very rare, but totally debatable. But I'd say those are the 3 things we care about.
I'd be taking any pills.
Yes.
And we're looking for allergies. I don't want to hear, and I've said this before, I'm allergic to sleeping pills. Why? They make me drowsy.
Yes. Not side effects, not the affected or the potential goal of the medication. Totally agree.
Right. Any other communication keys?
I would say that one other thing that can help communicate or make your consultation go more effectively is have a list of your medications with you. Because when, if it is a busy office and you've been in the waiting room for 2 hours and then you get asked your medication and then you're digging in your wallet and you're trying to remember, and you're playing like a little game with your spouse saying, what's the blue one or the yellow one or the red one?
Why do you care what medications the patient is on?
So I care because A, it tells me about your past medical history. B, it tells me about potential interactions of any medication that I'm going to talk about with you. So just helps change the goals.
And very occasionally, there's some medications that might be causing the symptoms that you have.
Sure. Like, remember when some of the cholesterol medications were causing muscle pain? So people would come in with, I got leg pain. And you're like, yeah, it's because you're taking this medication.
Some osteoporosis medications were related to fractures in the femur. So definitely important for the doc to know what key medications you're on. Blood thinners, you mentioned blood thinners. We're surgeons, right? So if you're on blood thinners, red flags go off. So
it means you can't have surgery urgently potentially, or we have to plan a little bit better.
A little bit of planning.
So in general, that's one of the reasons we do these videos. We're trying to communicate to our patients and to other physicians, here's maybe a slightly more effective way to get our job done safely. Yeah, and it goes both ways. Docs, you got to be able to communicate better with your patients and realize what you're trying to say. You're trying to tell them that if you can't help them, you have to tell them, I can't help you. It's not that there's nothing wrong with your knee or your hip or whatever. I just can't seem to help you. And patients, you really want to come in with the information, accurate, and be able to give to your doc efficiently. And to your previous point, I think that's the number one reason for a lot of the online doctor assessment sites for negative ratings is primarily because of communication. Even when I've seen some of them or heard a story, I'm like, listen, that guy probably didn't mean that, but I can understand how you heard it that way. Very personally, I know when I have patients that aren't satisfied with me over the years, it's because I didn't communicate effectively. Yeah, so it's for sure a little bit on us. So please, if you like this video, please like it and subscribe to our channel. Leave us some comments if you have any ideas about this. If you disagree with anything we're saying, please let us know. Communicate.
You see what you just did there? Did you see what you just did
I
there?
did.
You used our video.
I know.
You must have watched this video.
I did.
You have
I
a time
did.
machine or something?
Yeah.
And remember, you are in charge of your own health.
We'll see you next time.